Welcome to each of you. Thanks for joining us for the March edition of the monthly Journal Club series hosted by the Digital Medicine Society. My name is Sarah Sheen. I'm the moderator for today's session, and we're convened here today to discuss a recently released Journal of Medical Internet Research Viewpoint covering priorities for high-value digital transformation in cancer care. We're joined today by four of the article's authors, and are really looking forward to further discussion of its findings and recommendations. Before we get started, I'd like to actually take us through a set of housekeeping notes and panelist introductions so that you all can get a better sense of the structure of today's conversation and the perspectives presented throughout discussion today. I'll then run us through an article overview and a group of panelists' takeaways before we get to the panel and audience discussion portion of today's event. And I'll ask my colleagues to switch us to the next slide here, just to take us through brief housekeeping notes. I'd like the audience to ask the audience to note that today's session will be recorded and that the slides and recording will be available on the DIME website after we close out at 3 p.m. today. We'll also note that we'd love for you to engage during the audience Q&A portion of this discussion, and that you can do so in a couple of different ways. First one, by raising your hand and asking the question that you'd like to address to the panel live, and or by typing your question into the chat box down at the bottom of your Zoom screen here. As you'll note on the agenda for today at the bottom of this slide, the Q&A session will take place at 2:45 and will carry us through to the close of the event at 3 p.m. Before we get into an article overview and panelist takeaways, I do want to make sure we introduce the panel. Again, I'll start here. My name is Sarah Sheen. I'm a program lead here at the Digital Medicine Society and the program head for the forthcoming oncology project that we are co-hosting with the Moffitt Cancer Center. And we've got four esteemed colleagues and panelists here. I'd like to pass the mic around so they can introduce themselves. Edmondo, you are first on my screen. If you wouldn't mind just briefly introducing yourself.
Sure, thanks, Sarah. So Edmondo Robinson, I'm a academic hospitalist, health services researcher, and the chief digital officer at Moffitt Cancer Center here in Tampa, Florida.
Thanks, Edmondo. And Dana, you're next on my screen, if you wouldn't mind.
Sure, thanks, Sarah. Hi, everybody. I'm Dana Wolf-Hughes. I am a program officer in the Epidemiology and Genomics Research Program within the Division of Cancer Control and Population Sciences at the National Cancer Institute.
Thanks, Dana. And Grace, we have you next here.
Hi, good afternoon, everyone. I'm Grace Cordovano. I'm a board-certified patient advocate specializing in the oncology space. My day-to-day is working with patients and their families from point of diagnosis through survivorship or end-of-life care planning. I'm super excited to be here today.
Thanks, Grace. Appreciate it. And Smith, if you could run us out.
Absolutely. Thanks, Sarah. And it's lovely to be here. I'm Smith Patel, Associate Director here at DIME, focusing on regulatory and clinical aspects from the implementation science, supporting advancement of safe, effective, ethical, and equitable use of technology.
Great, thanks, Smith. And thanks to each of you for joining us today. We're really pleased to discuss the article, which is an articulation of findings from a 2021 roundtable convened by DIME and the Moffitt Cancer Center, focused on discussing the state of digital innovation in cancer care. And I'll just ask my group here to display the slides as I run through some of the overview of the article from my perspective. And I think we can also maybe drop the article in the chat for folks who haven't recently read or are joining us new. So you'll see here that the discussion at the roundtable I just mentioned had two objectives. The first, to define areas of unmet need in cancer research and care that were particularly suited to digital intervention. And the second, to identify the drivers of successful digital health innovation to support improved cancer care and research. And what's articulated in the article, you'll find that discussants found, several things of note, including that despite the fact that oncology is a leader in innovative approaches to research and care delivery, digital innovation is lagging behind in oncology relative to other therapeutic areas, and advancements in digitally enabled care are not standard of care for all patients with cancer. Roundtable attendees, as part of the discussion, discussed how the field stands to benefit from the use of digital innovation, digital solutions at scale to help us streamline treatment pathways, harness disparate flows of data to support improved decision-making, and address the cost and administrative burden that accrues to patients during cancer treatment. Finally, participants identified priority challenges across the cancer treatment lifecycle, from R&D to care personalization and coordination, that were particularly well suited for digital innovation. And as we work through today's discussion, I find that table 1 in the paper, the JMIR paper, is particularly helpful as a guide to where we think the most progress can be made for the most patients with the implementation of digital tooling to support improved care and research. So I'll move us right along to discussion here, but first I'm really pleased to invite our panelists up to share their own key takeaways from the discussion and the paper about how we address these challenges to reimagine the systems of research and care via digital tooling in such a way that these systems improve outcomes for a broader and more diverse coalition of patients. And Smit, as first author, I think it's a natural place to start with a group of key takeaways from your perspective. If you wouldn't mind kicking us off with just a couple of thoughts here.
Absolutely. Thank you, Sarah, for that lovely overview. And I think, it goes back to the question around Roundtable, where we had brought in over 40 different leaders from over 35 organizations to test this hypothesis that we had. Is what we have seen across the field in different therapeutic areas is, digital is being used during COVID, be it mental health, be it cardiovascular diseases. But when it came to oncology, there was still a lag. We know there's so much progress that is happening, but in the world of digital, it was still lagging. And there were a multitude of arenas when we talk about, I'm going to start with one of the early ones that we saw was in the research and the development space. When we think about the endpoint measurements, and as we think about the performance status measurements for patients that are either episodic, where high value information that we are collecting through a lot of these sensor technologies, what are the right endpoints? How can we define the core measure sets that are actually that matters to the patients or individuals living with cancer? How do we measure in a more effective and objective way the quality of life assessments? And then these scientific methods combined with the complexity of care coordination was so large that it was kind of like cancer is hard, it's complex, it's heterogeneous, and then you put in these scientific approaches to measure that using digital was this humongous thing. So I want to pass it back to other individuals as we found a lot more and hear what they thought.
Yeah, thanks so much, Smit. And yeah, Grace, invite you up to share your takeaways as well.
So in speaking from the patient and care partner perspective, there were so many things that stood out just from this process and then the culmination of this beautiful paper that was published. I think table 1 in the paper, I may be biased as one of the participants, is one of the most powerful references and resources that someone in the oncology innovation space can have. I almost want to take photocopies of it and hand it out with me when I go to a conference, because I'm frequently approached to say, oh, I have this new innovation and we're all patients, and I'm just going to give it out to people and say, you need to read this. And if it doesn't check all of these boxes, you have to go back and do it again and include the patient and care partner perspective and really hone in on what matters. Some of the key things that really stood out to me, and really some feedback that I've received from patient communities who were very intrigued by this paper, was the beauty of including financial toxicity and a lens on the administrative burden that patients encounter in their life with a cancer diagnosis. When you think about advancing digital health and oncology, that's very sleek, sexy, AI, ML, NLP, lots of sophisticated tools and technologies, clinical decision support. We never hear about financial toxicity, which the majority of people with advanced cancer and even early stage cancer are struggling with. And then the administrative burden. In my opinion, from doing advocacy work for now over 25 years, personally and professionally, the patient administrative burden that people encounter, or the work that people need to do to get the care they need, is really a huge barrier. And it really severely impacts our traditionally underserved communities where there's significant barriers due to social determinants of health. And I think that's where we could make great progress connecting people to the care they need by strategically and really smartly understanding patients' unmet needs, using Table 1 and taking the tools and technology from a digital health standpoint. And really, that's where the magic's going to be.
Yeah, thanks so much, Grace. Yeah, obviously a huge opportunity to reduce patient and provider administrative burden, right, as we connect folks with, high value digital intervention. I'd like to round us out, Dana and then Edmondo, if you all wouldn't mind sharing just high level thoughts before we move towards discussion. And I think we can start with Dana here first.
Sure, thanks, Sarah. So, Smith, your focus on research and development, I think, is really key to sort of start us off from a digital lens. I think what we heard in the roundtable is that there's been a lot of technological development that's occurred in a lot of other areas that may be able to be leveraged in cancer, but it's not fit for purpose for cancer. There's also still gaps in technology in general where we just need to build new devices and platforms. But it doesn't matter if we build the technology. To Grace's point, we really need the patients at all sort of phases of this development, their voices at the table, because they're ultimately the ones that are going to be using these technologies. And we know from an engagement perspective, long term, there's a drop off. And so I think there's tremendous opportunity across all sort of phases of the cancer control continuum, from prevention and screening to treatment and diagnosis, to even where I sit in sort of epidemiology and like surveillance and using these technologies. But we really need to think about what is easiest to use, what's the least burdensome for patients and participants to use these technologies. How are they engaging with these technologies? What does it mean to them? How are they vested? And how can we then build that evidence base to then convince the clinicians, regulators, others who may be taking and leveraging these technologies to actually implement them? Because I think that's another portion of this that we're seeing is that there's a lot on clinicians' plates, there's a lot on patients' plates. Giving them a technology is one more thing that can be viewed as burdensome. So we really need to think about how we can optimize this to make sure it's meaningful for all stakeholders.
Yeah.
Sarah, I want to follow up, since you said I was going next anyway. So I want to follow up on Dana's point, and as you think about the clinical operations side of things, and that's the world I live in, day to day. It's amazing how backwards technology implementation in healthcare has been. And what do I mean, right? So it's the idea that every time there's new technology, it actually makes it harder for everyone, not easier. It's insanity that's happening. And so, we're not making it easier. We're, that burden that both Dana and Grace referred to, where we're making it harder both for the clinicians and providers as well as for the patients. And your digital tools technology should be improving your experience and improving your workflows and improving your clinical operations, standardizing your care delivery, so that you're optimizing your actual, and everyone's getting the optimal care and the best care. Your digital tool technology should be helping you with that, right? So we talked about that in the paper as well. Your standardization around your care delivery models themselves, and I can't leave without mentioning data, right? Data. And so cancer care generates a ton of data. Those data do not turn themselves into insight as readily as they probably should. And they certainly don't go from insight into actual action or intervention the way they should. So how are we actually leveraging this asset of data, standardizing it, governance models, all of those pieces, so that we're actually using it to drive back to, again, personalization, easier ways to interact and integrate with the system, ways to clinical operations, and how are we using those data? Because I never miss an opportunity to throw in how are we using those data to, and Grace mentioned this as well, to actually provide equitable care. How are we using those data? How are we using our clinical operations? How are we using our digital tools and technology to drive down disparities in cancer care versus exacerbate disparities in cancer care, right? So all of those concepts, again, were, to me, I want to pull those pieces out of the paper.
Yeah, this is all great, and I'm looking forward to a deeper dive into kind of each of these issues that you all mentioned here. I think, at the foundation of this discussion should be and is the equitable and patient-centered deployment of these digital solutions, right, in a way that does not exacerbate existing inequities, helps us drive towards better leveraging of data that we produce within our health systems at the point of care, and of course outside of our health systems in patient life, and really drives us towards a learning healthcare system, right? Continuous improvement from the ClinOps perspective. So I really like actually the order that we've gone in here, and I want to move us now past the key takeaways portion towards the discussion portion of the workshop here. And I think we'll start out at the beginning, right? Smit, you mentioned here about the complexities of cancer care, right? And we know that is more often than not team-based care. And there's a quote in the paper about clinical pathways for oncology not being comprehensive enough or adequately adopted at scale. Was hoping that you could plug in and expand here about what that means to you and what that meant during the workshop discussion, and what the consequences of this, inadequately optimized clinical pathways for cancer care delivery are. So I'll leave it at that to kick us off, if you wouldn't mind, Smit.
Definitely, that's a loaded question, and we can have an hour discussion on that, but I'll try to do the justice. Sarah and everyone who's joining, if they, as a clinician, it's one of the things that we think about if we are treating a patient who has hypertension versus diabetes, compared to if you're treating a patient who has a triple negative breast cancer or prostate cancer or small lung cancer. They are completely different based on the complexity and the heterogeneity of it. There are multiple components to it, and let me go into a few of them. If you think about from the epidemiological perspective, there are over 50 major categories and multiple disease presentations that comes out of like the disease states, the lab values, genetic variations of hundreds of different disease presentations that can have for individuals who get diagnosed with cancer. And then we think about types of cancer, it's breast cancer, prostate cancer, colon cancer, pancreatic cancer, to the spectrum of all the leukemias and lymphomas. We have evolved over the last couple of years. And if you think about it for the last decade, and I remember the statistics because it was very close to my birthday, it's like in 1990, it was around like 37 approved drugs that were available for 60 indications. But today we have over 500 anti-neoplastic drugs available. And as we increase the research, the learnings and the data points are increasing. And let's take a look from what Grace mentioned is from the patient's perspective and the touch points. They have a caregiver who supports, they have a care navigator who helps navigate through it. They have case managers from the financial perspectives who can help navigate how to get it paid. They have nurse, they have GPs, they have surgeons, they have oncologists, they have pathologists, they have pharmacists, they have phlebotomists, the X-ray radiologists. Like there are so many individuals and touch points. And then you think about meeting all of these care providers across the journey. And as Amanda mentioned, the data that it collects is massive. It's more than like a CVS receipt at this point in terms of the list of individuals that they have to take care of or talk about. And then we think about from the clinical perspective, the burden that clinicians have. It's in US, I think it's staggering, 160 oncologists for 1 million US patients, which is incredible. To get an appointment with an oncologist when you are diagnosed, it's so hard. And there are less than 5% African-American or Black oncologists who can provide targeted care for patients of color. So there are multiple different challenges when we think about cancer care as a whole, being heterogeneous, being interconnected and interdisciplinary, because if one piece is missing or if one data point is missing, there's a domino effect on a patient's outcomes and patient's experience at the end. So those are some early thoughts there.
Yeah, thanks so much, Smid. Obviously complex, and it seems like increasingly complex. And later on top of this, right, might be the implementation of digital health solutions that, on their face are attempting to make care less complex and obviously reduce the administrative burden on patients as they attempt to receive care or perhaps participate in clinical trials beyond just receiving supportive care. Do others on the panel have thoughts about the opportunity here to work across in an omni-cancer way, right? We're talking about there's disease-specific differences across the different types of cancer that a patient may be diagnosed with. What's the potential here for us to be able to solve for problems in a way that helps the most patients across the cancer treatment spectrum? Do folks have thoughts right off the bat on that?
There's one thing I'll throw at is, and it's going to seem like it's coming out of left field, but it is a little bit, but I'm going to share it anyway. So one of the things I had an opportunity to do was randomly I chaired and facilitated a summit in Virginia, sponsored by Senator Tim Kaine, on long COVID. Okay. So Senator Kaine has long COVID, and he wanted to bring all the providers around to talk about, like, and patients as well, and say, like, how are we managing long COVID? Okay. So one of the things that comes out of sessions like that is, hey, we should be more like oncology. We should be more like cancer care. And I was like, well, be careful what you wish for, right? Now, again, long COVID is complicated. It's hard to diagnose. There's, it's a myriad of diseases. So I can see the similarities. And we do have, generally we have a better team-based model of care in oncology. So I can see where there's similarities, but at the same time, and I know Grace knows this, one of the challenges they had in long COVID is, for example, how do I navigate the challenging system of declaring that I have a disability? Just that process of just disability, right? Now, it's a complete hot mess in long COVID. I guarantee you it's not better in oncology, right? And that was mentioned in the paper. One of those things where you say, hey, is there a way to streamline the process, make it more personalized, make it more efficient, be able to make the decisions? But all of these things, yes, there's opportunities to do all of these things. And I think sometimes we get so wrapped up in the biochemical or the digital therapeutic or and we forget about just like how patients just navigate the broader health system, not just the healthcare system, and where there's opportunities for digital tools to help facilitate that.
Yeah, thanks, Armando. I think that's a great response, and also ties back to, I think, Dana's point about lessons learned from other therapeutic contexts that we can transport and adopt in oncology care and, of course, research, but also, oncology-specific gaps that we have to fill, and that could be potentially disintermediated through the use of digital solutions. And I want to make sure we're moving it expeditiously towards, the Q&A portion of this and covering all that you all covered in the paper and 2021 Roundtable. So, Dana, I was hoping you could pop in here to talk about how this manifests from a data perspective, right? So we know that effective cancer prevention, care, and research require the facile exchange of large amounts of data and information. We just talked about this a minute ago, and I was hoping that you could plug in from your perspective, right, and talk about the data-related challenges, that are associated with cancer care and what impact they have on providers, patients, and outcomes.
Definitely, and I forgot to mention before, sort of when I talk and respond to things, sort of these are my views and not necessarily the official position or view of NCI. But to Edmondo's point, I think about long COVID, I will say one of the benefits with cancer, at least, is that we know what cancer is, and having worked in the long COVID space, I think that's part of the issue. But similar to what we're seeing in oncology with these digital tools, we don't know what the endpoints are and what those digital biomarkers are and how they mirror onto disease. And sort of before I answer Sarah's question, I'll just sort of wrap up to say that I do think that there's a lot of potential to make a connection with cancer and long COVID. We know that people's health behaviors are vastly disrupted when they get long COVID. And that alone, their disrupted sleep, their sedentary behavior, their poor diet, their fatigue, and other issues are all risk factors for cancer. And so I think, we should start thinking about how we can track people long term with these digital technologies. to understand how that's going to impact their cancer risk. But to Sarah's point about this data, and I see sort of some comments in the chat about that too. I think that there has been a lot of progress, albeit slow, to facilitate data exchange and access, but there are still a plethora of different challenges that are really multifaceted that really need to be addressed here. And they range from standards and interoperability to the ability to aggregate and link. And that's not only within sort of the health system, but it's patients, the burdens on them right now for them to do a lot of that work. And so just taking it very, very simple, you know, I like to lean on physical activity as a great example, because we know that physical activity is related to cancer and it's a modifiable risk factor. But even just as a standard, we don't currently have a standard in the EHR right now for physical activity. That doesn't exist, and there's some work being done to try and work on that and have that added in through USCDI. But the conversation right now is just focused on the self-report screening of physical activity. It's not even right now at the level of developing sort of a standard for the digital tools, because we just don't even have a standard for that. On top of that, we need to make this meaningful, right? So a lot of EHRs now have the capability for people, and patient portals have capability for people to share their data. The clinicians don't know what to do with that, right? It's a ton of data. They don't know how to make meaning of that. What does that mean for the patient's care? How are we going to personalize their treatment? I think there's tons of opportunities there, but we need to figure out how to make this what I like to call, talk a lot about like sort of the minimum viable product, but it's almost like in digital health with all this data, what's the minimum viable like assessment that we need that's clinically useful? And it's going to vary, right? But I think that we need to think about that, because we just don't know what to do with this data. And so what happens is that the data isn't being used, it's not housed in the same health system, patients are going from provider to provider, the level of interoperability varies, and so the timeliness of data exchange and making meaning from this data to inform care really sort of slows down and impacts overall quality of care. It's not only extra time for everyone involved, and it's not only a burden, but it also adds undue stress. And we don't need patients being stressed during this time. If they have enough stress, they have enough on their plate, and we know stress is also a risk factor for different negative cancer outcomes. And so ultimately, I think we need to think about how we can leverage this data to make more timely decisions, as well as personalize it to the patient, as well as gain insights to further our development in R&D. And I see Grace's comment. Yes, USCDI has physical activity as a draft. It's a screener using Kaiser. Grace, we should follow up offline more about that.
Yeah, I really like the idea of maybe like a minimally acceptable core set of measures that we are already collecting, right, as part of routine care that can enable us to best leverage the wealth of continuously produced health data, right, within our systems to drive towards insight for clinical decision making, and to reduce, obviously, the patient burden of having to coordinate all of their data together, right, to help inform care, either giving that data to practitioners or trying to figure out how to make sense of it themselves. And I'd like to maybe just move us on here to talk about this from the health system perspective, right? So we have the capabilities and the infrastructure to do a lot of this, right? And the digital tools exist, right, to help us improve patient care delivery and in theory, right, patient outcomes. But we've noticed a lack of uptake, right, on behalf of health systems, especially in the oncology space. And Edmondo, I think, is that the health system resident here. I was hoping you could provide that sort of perspective, right? So why do you think that is? Why is the uptake lagging, even in centers, right, that are particularly bent towards digital innovation? And what are the consequences of that lag?
So in general, change is hard, especially in healthcare, right? So It reminds me of the old Sam Cooke song, "A Change Gonna Come." Anyway, so that's it's not quite that easy. So we already know that in healthcare, getting people to even uptake, peer reviewed, well done, RCT level data is hard. What's interesting in technology, right? So it took, in order to get 40% consumer adoption of different technologies, it took the telephone 64 years, electricity 45 years, computers 23 years, mobile phone 16 years, radio 12, internet 13. This is 40% consumer adoption. Okay. Now, here's the thing. One, consumers are not health systems. They're very different. And two, it's a long process, right? So, part of the reason why healthcare gets stuck is because you get trained, right? These are highly trained people doing what they do. And if you have a new technology like NLP or something like that, I guarantee you there's very few senior full professor level faculty members in oncology who are trained with NLP as in their training. When I say very few, I mean like zero is my guess, right? So so now you've got a group of folks, who are doing their thing, doing their clinical research, taking care of patients, and then you're saying, hey, I'm going to throw this whole new thing on you. Go figure that out, and then implement it, by the way, as well. And and then stop telling me why it can't be done, right? That's what we're asking folks to do, and we're also asking them to do that. And the digital companies that are bringing these innovations in are not helping themselves. Why? Because they come in with these point solutions and these myopic views about how a patient's journey goes or how a clinician's journey goes. And they say, hey, I can solve that problem right there. That one right there, I can solve that. And you're like, okay, maybe that's helpful, but I have this entire universe and ecosystem of problems, and you're solving that one. And you want me to spend all this time to rework my entire workflow because you can solve that problem. We haven't, the digital tool and technology haven't come to these challenges with an entire ecosystem, an entire journey, an entire persona approach to things, a platform kind of approach to things. And so they're wondering why they're not getting traction, right? Like how much change do you think folks can go through at any given time? One of my old titles back in the day was Chief Transformation Officer. Imagine that, right? Chief Transformation Officer in a health system. Boy, was that I'm surprised I have any hair left after that job. But one of the key things, and again, this is what folks don't fully understand when you're trying to implement these tools, is you don't implement technology in a vacuum. You've got to understand let's call it the milieu that you're working in, right? I call it the people and culture part first, right? People, culture. Are we even ready for change? Readiness for change is readiness for change models. All those things are actually well documented. They're not used, but they're well documented. And then it's workflow and process, right? And optimizing those, including getting rid of workflow or processes that you don't need anymore. And then it's technology implementation iteratively with the workflow and process optimization, right? So change, people, culture and people first, workflow process, iterate with the technology implementation. So few folks approach it that way. And so many of these implementations fail to either actually get started or to stick over time.
Yeah, thanks, Armando. I really like those themes here, especially from the paper, right? Picking up on the implementation of a cohesive digital health strategy for an integrated health system, no small feat, right? And of course, coupled with the workforce training requirements there. And we think about that a lot at DIME. And I know that came up in the discussion and was reinforced in the paper as well. And I think we spent a good amount of time talking about the causes of the, lack of uptake across health systems and elsewhere of these digital solutions. But I do do want to make sure we round out this portion of discussion with what's at stake, right? The consequences of this lack of uptake. And Grace, I was hoping that you could plug in here to really help us bring the patient to the center of the discussion and talk about the impact of the slower and more narrow uptake of digital tooling on patients. And maybe if you could provide a couple of examples about how you see these issues manifesting for patients as part of your work, I think that would be a good structure for us going forward.
I think one of the most frustrating things for me is I have the privilege of being an invited speaker at conferences. So I have the opportunity to walk through exhibit hall floors where all of these new shiny technologies are on display and everyone's so eager to show me. And then I come back home and I'm in Northern New Jersey. I have the privilege of working at a lot of cancer centers of excellence, both in the tri-state area and now also virtually. No one is using any of these technologies. I work with clipboards with a cute little rubber banded pencil. Patients just don't have access to biomarker testing. There's no clinical decision support. Patients want AI powered tools. We want to work smarter. See, when you get a cancer diagnosis, it becomes a ticking time bomb. Your mortality hits you in the face. Your loved one, and if you're navigating this for your loved one, you're willing to literally catch a grenade. You're up all hours of the night trying to find information. Every single person that's diagnosed and their care partners and caregivers are reinventing the wheel instead of strategically working smarter to be powered by the data to know what they need to do now and what they need to do next. That's the biggest question that I get. And instead, what we do is we hide behind labels such as patients are non-compliant, non-adherent, they're too lazy, they're too illiterate, they're not motivated, they need behavior change, they need nudges, they're frequent flyers, they're drug seeking, and all of these labels. When really the behavior change needs to happen on the ecosystem side, because 9 times out of 10, it's not the patient that's the problem. It's the fragmentation and our poor foundation of an implementation and operas that, making these systems operationalize the patient to work smarter. And I think we need a culture change here. We need to move away from the doctor knows best to the doctor and the patient and care partner and care team have shared accountability, which means we have to level the playing field for the people that are diagnosed by cancer. And we have the information out there. We have the tools. We have the technology, but we're not bringing it together. It's not just a point of care thing, because cancer, believe it or not, happens outside of the exam room and the 4 walls of medicine. So that has to go home with the patient where people are living because they have tasks to do. So for example, going back to Social Security disability applications, here's something that I'm going to propose. Once that cancer diagnosis happens, medical records need to be a thing. That access to that foundation and that truth, we need to teach people how to get access, the power of that access, and what that access can do with respect to use cases and tasks. What do I mean by that? You need your health information, not just for your cancer care, but to appeal insurance denial, set up a second opinion, apply for Social Security disability benefits, connect to community supports, review your billing and see if there's errors there. There's so many tasks and we're failing patients, which means what happens at the end of the day, because of poor uptake of digital tooling and digital health, we're giving a competitive advantage routinely to cancer instead of to the person living with cancer. And that is unacceptable.
Yeah, thanks, Grace. I'd actually like to stay here on this access piece and talk in this next section about what we can do about all of these issues, right? Starting with access. And Smith, I was hoping you could plug in here to talk about, how digitization can support the democratization of clinical decision-making and help us extend access to high-quality digitally enabled care to a broader and more diverse coalition of patients, right? These are the folks that Grace, you mentioned, maybe don't necessarily have access readily, right, to some of these digital interventions that can help support improved outcomes and also make a difference on the quality of life measures that are important to patients as they live and survive with cancer. So Smith, any first thoughts on, kind of this access dimension here and how we can support better access with digital?
Absolutely. I'm going to share something building upon what Edmonda and Grace had said and also something that I learned from working with VA colleagues, and Brian Vega, the chief officer at VA, always says that we care for veterans, not we deliver care or provide healthcare. I think we need to reimagine our approach for cancer care as we think about caring for individuals with cancer instead of delivering care to cancer patients or providing care to cancer patients. And I think this approach will change a lot of things because, access is not just about giving a digital widget to an individual about, hey, use this wearable technologies and we'll measure your physical activity, or like, hey, these AI/ML approaches are going to help with diagnostics. We have to think about access more in a broader term, even beyond the digital technologies, thinking about time. And I think doctors' offices are open from 9 to 4. Do people have cancer problems only in 9 to 4, or do they have throughout the whole day? Like, how do we think about providing and having the access to care 24/7? Or we think about cost, and I'm going to give you an example which was quite powerful. Recently, I read Kansas Cancer Center. One of the researchers out there had reviewed 16,000 claims data and then correlated that to the access to telemedicine visits and the patterns behind. What she found was over 75% of people who are diagnosed with cancer, 70% of them who had access to telemedicine visits were from higher socioeconomic status. And half of them, less than half of them, were individuals with lower socioeconomic status. I'm going to add something to that. Think about uninsured patients. Think about patients who don't have, or immigrants, or are undocumented, who don't have the payment pathways to even access these telemedicine visits. For them, we are talking about access which is absolutely nil or just scraping through them. So I think we need to reimagine when we talk about access to not just the technology. 90% has a smartphone access. We can create a software solution deployed for cancer management, but rather access in a term of caring for individuals with patients. And I think that's how we can improve this concept of access beyond just technology.
Yeah, thanks, Smith. And I like this discussion around the importance of and preference for asynchronous care, right? That fits in with daily life for patients as a way to reduce administrative burden of dealing with cancer. I think it's a cost issue here too, right? You mentioned payment policy. Obviously, there are payment pathways that we should discuss here, and probably could have a whole other roundtable on. But Grace, I wanted to come back to this idea of financial toxicity, right? And obviously, there's inequities in access, right, that affect more some patient subpopulations more than others, but there's also a disproportionately large cost that accrue to some patients versus others across the cancer treatment life cycle that we have termed, financial toxicity, along with the literature that exists around this issue. Can you talk a little bit more about how you see digital helping with that, addressing that, right? Is it providing access to care at a 24/7 rate, making sure that we're extending the footprint of, kind of care provision into patient homes? What does that look like? And how do you see it working going forward to benefit the most patients?
First of all, I could talk about this until next Tuesday, so I'll try to be brief. I would say there's probably top things that I see that contribute massively to costs. And when I say costs, out-of-pocket costs for a patient, I would say delays from that point of diagnosis to confirming a diagnosis to treatment. I'll give you an example. The patient is in surgery now at a local cancer center. It took 10 weeks for a patient who was diagnosed with a pretty serious cancer to get an appointment. That is unacceptable. 10 weeks to get an appointment. And this was a patient that was diligent about getting their records, diligent about getting imaging, diligent about getting slides. And this is unacceptable. How can someone wait this long with an urgent diagnosis? Another cost contributor, not extending biomarker testing. We've been talking about personalized medicine forever, and most patients with a cancer diagnosis don't get offered any type of molecular or biomarker testing. It's not even a discussion point. So because we don't do that, we are missing opportunities to connecting people to the right therapy at the right time. We're not introducing clinical trials at time of diagnosis. We're waiting until it's too late and the patient then no longer meets the inclusion criteria because they've been treated with too many lines of therapy or they're just too sick. Transparency. So transparency about costs, we see some improvements on the No Surprises Act with billing, but the way that the billing flows to a patient, I'm helping a patient that has literally received a stack of bills in the amount of just under $1 million for an outpatient procedure for something that was pre-authorized. So now to dig out of that, I guarantee there's probably some claims that need to be resubmitted, but how can the average human being handle something like that while recovering from a surgical procedure? So these people give up. I have sat with people as they contemplate bankruptcy, divorce, fleeing the country, suicide because of their bills. That is not acceptable. So we don't even talk about that. So I can't tell you how much I applaud this entire group and effort for acknowledging the role of financial toxicity, because we can solve that and we can certainly incrementally improve that. And I think by working smarter and faster, connecting people more quickly to the care they need, naturally reduce cost on both ends across all stakeholders.
Yeah, thanks so much, Grace. And I really appreciate you sharing your perspective here, right, as a connected patient advocate. And I think this underscores the importance of getting patients connected and connected quickly, as you said, to the right evidence-based care. And I do want to take a few minutes to wrap in that kind of discussion towards the end of our session here. And maybe, Dana, I can pivot to you. It's clear that we all have a vested interest and a responsibility to, improve the representative nature of clinical evidence generation in a way that reduces some of these health disparities and cost disparities and improves therapeutic access more broadly and equitably for the patients that Grace is talking about. And the paper discusses, I think, extensively opportunities to leverage digital tools to support the collection of higher resolution data on harder to reach patients. And I was hoping that you could plug in here to discuss how we might go about implementing these types of tools to really help us address inequities in cancer risk and cancer cost, disease incidence and burden, and of course, importantly, clinical outcomes.
So I think that's sort of really large and there's so much that can be done. I think we can implement at all phases, right? But I think to think about this, we really need to start thinking about at the beginning with developing equitable and inclusive technologies and deploying them in an equitable and inclusive way. And I know Dime has done some great work in this area with developing resources for equitable and inclusive deployment and development of digital health technologies. But I also think too, what'll be helpful, at least from my perspective, is that going back to the clinician and getting the clinician uptake, if the clinician says something to a patient, a lot of time they're really they want to do it, right? And I think there's an opportunity there, and getting them on board, building that evidence base and demonstrating the effectiveness of these technologies is gonna help, but it is not the full solution, right? This is going to be a multi-pronged approach, but to the implementation on the patient side and what's meaningful to them for inequities, I really think that we need to think about developing an infrastructure of access and engagement here. It's not, to Smit's point, just giving them the technology. There are multifaceted issues here. Some people need broadband access. Some people need help with setting up their device or troubleshooting. Maybe they understand the device, but they have some sort of other issue and they need assistance. Maybe the clinician needs assistance as well. We need to be providing them opportunities for training and education and development. And so I think that we really need to think about not just infrastructure as data, right? Infrastructure as people, and how do we bring them to the table? What's meaningful for them? Some populations, they want to use these technologies, but they're skeptical. They're worried that their data will be used in a way that's not beneficial for them. They have privacy and security concerns. Engaging community partners may be the solution for those individuals. And so I think that we really need to think about how we engage communities, advocates, to understand the types of data that are meaningful to the patients at different stages of care, because that may change as well. Preference for devices, we've seen some patients, they really want to use this device, others, they want to use a completely different device. We should be thinking about how we can facilitate that for them, provide for those who may not have access, reducing barriers and addressing their concerns and challenges. And I think in doing so, we're going to see that they're going to take the technology, they're going to use it, they're going to be able to do more than we think, to Grace's point. It's not about the patient and making excuses for everything the patient may not be doing. I think that's a cop-out, to Grace's point, but I think that gets them to the table in a way that we haven't been doing. But we need to start with providing them that community and engagement infrastructure to help support that. And I can go on and on about that, but I'll sort of pause there.
Yeah, it's a huge topic and fully recognize that. And we have a short amount of time together today, but I like this idea of continuous engagement with patients to build, trust, to provide assurances about privacy, and to ensure that their data is safely used and can be reused, right? To help support continuous learning in our health system, and ensure that they're deriving value out of the data that they're providing, right? It's their own property. And I certainly, resonate here with some of the themes that you've brought up. And we're really close to the end of the hour, and I want to make sure that we're able to incorporate questions from the audience as they come up. And there's been some great discussion in the chat about e-consent models, things of that nature. I'd like to make sure that we're getting anyone online that would like to participate. So before I move on to this last question for you, Edmondo, I want to make sure that folks are plugging questions into the chat. And of course, there's an opportunity to go off mute here and ask questions of the panel in just a second. So before we close out, I think to address a really large theme, in addition to patient engagement and continuous learning, Edmondo, ideally as we are implementing this type of digital innovation to support improved care delivery, right, we are moving towards a learning healthcare system, right, one that continuously engages patients and that allows for the use of patient and other types of data to support, system learning. So can you discuss briefly, and I emphasize I'm briefly here, how we can get closer to the integration of cancer care and research within integrated health systems, and what the benefits, of that would be for us as a system.
And I'll be brief, Sarah. There's two concepts I think we'll have to incorporate, and they're neither one of them is easy, but I'll throw both of them out there. So one is we actually have to standardize. So you standardize your care so that you can see variation. Right. So if everything's variation, you can't pull signal from noise. You standardize your care first so that then when you're testing around variation, you actually can see whether or not it's truly impacting and whether or not your standards should change or that variation actually is not good. So standardization is actually first, and that has to go across the board. And then the second piece is the trials have to be better designed to be operationalized from the very beginning. So one of my concepts is, we don't do pilots. Right, because what happens with a pilot is you don't design the entire pilot so that you can operate, so you can scale it if it works, right? So instead, I say we just do MVPs, minimally viable products. That way, you're designing it so that if it works, it scales. So the same applies to research, right? I understand that we've got to get your science has to be good, but you've also got to have an operational mindset, a translational mindset. Especially with digital interventions.
Yeah, thanks so much, Amanda. And there's a huge translational science piece here, obviously, and I think that goes back to the adoption at scale and the change management issues that you were bringing up earlier. I want to make sure that folks online have the chance to ask questions. So I'll pause here for a few seconds. Does anyone want to jump in with a question for the panel? We've got about 5 minutes left. All right.
Hi,
Yes.
this is Archana. Can you hear me?
Yes, of course. Please go ahead.
Hi, thank you so much for this lovely discussion today. And a lot of things that we discussed really resonated. And of course, as a fellow co-author on this paper, I know too well the pain points and the potential for all these solutions that exist that need to be leveraged better. My question is, specifically with regard to the financial toxicity. We always talk about uninsured or immigrant population, but when I think about even the insured ones, take for example, I just lost a very close relative last week to lung cancer. And believe me, even for reasonably people who can afford the cost of living, just the co-pays can be financially debilitating for, as well as, all the ancillary costs that come with going through a cancer treatment journey. So my question to this panel is, how can this industry and how can we work together to even address those needs? Because people, the thing what Grace said, people are thinking about fleeing the country, suicide, these kind of notes, thoughts and actions that drives these families, even middle-class families, that get impacted in a huge way. And I think we owe it to the patients and their caregiver families to make sure that they don't go into bankruptcy. So how, what can we as an industry work together? How can data be leveraged so that the cost of development is not so expensive, so that the medications are reasonable and affordable and better covered and better, through the insurance, evidence is there so that we can force these insurance companies to cover fully and not partially. I'll pause.
I think I'm just going to chime in and say that from my experience, you raise at a very incredibly important point. Underinsured individuals experience routine financial toxicity and have less access to any type of assistance because they may be above what the income limit is, or they may not qualify for the patient assistance program that a manufacturer may have. But how do we drive down some costs? I'll throw out one example. Clinical trials should be designed with patients and care partners, and I will throw in a new word, surviving care partners. The individuals who walked the walk with their loved one and their loved one died, especially in the context of a trial, we do a terrible job of then welcoming these individuals who are experts in the process to share feedback to prevent the sloppiness in our trial designs and to work smarter and make them decentralized. So I think having a line item to hire these people as not just a token focus group, but as advisors to design will not only shave time in your design and development of your trial, but make it something that's more real world accessible to more people, hopefully then in theory driving down costs of drugs that are manufactured.
Great, thank you, Grace. I also noticed Edmondo's comment here. I think it's going to come to patients sitting up and demanding this now. I think we need to, because industry has been given a lot of time to address this. This has been a known problem. It's not a new problem. I think that it's time has come where patients are going to need to demand this of their caregivers, of their care, clinics or hospitals that they go to, and insurance companies that they work with through which they buy their insurances. I really feel that's the practical solution, perhaps. And Edmondo, I would really welcome your thoughts on that. Yeah.
I mean, so in Grace and we've chatted about this like a few times before. It is that I think that's going to be really critical. So, for example, some of the challenges that have come up that are policy based, for example, whether we're talking about the payment structure and in the country, or again, I mentioned this idea of disability. It's going to be really hard for the health systems to drive that change without the patient. Right, that's a patient really led change if we're going to be addressing those things, and we'll come back behind and say, yes, we got your back, but the patients have to do that. So I think it's a really critical point that you're bringing up. I know we're out of time, so I want to pass it back to Sarah.
Yeah, thanks so much. I do wish we had at least another hour to discuss all of these, policy considerations, and of course the patient-led transformation, right? And our trials infrastructure, our payments infrastructure, and our health system and care delivery, infrastructure as well. I think plenty of themes to pick up on. We are convening work around these particular issues actually over the course of a 15-month project, which kicks off towards the end of this month, and would love to have folks from around this table engaged with us in that work. And with the slides and recording from today's discussion on our website, you'll find information about that project, which we're co-convening with Edmondo and his group at the Moffitt Cancer Center. We are over time, and I do want to make sure to honor everyone's time. Thank you so much to each of you and to the panelists for joining us today for what I think is a great discussion that should set the foundation for future work. There's a lot of it to be done, and we look forward to engaging with each of you over the course of the next years and years to come to address some of these financial toxicity and equity issues in oncology care. So thanks to each of the panelists again, thanks to each of you for your attention, and we will close out here. Have a good rest of the day, everyone. Thanks again.
Thank you.